everyone. Today we'll be talking about urinary tract infections. Urinary tract infections, commonly known as UTIs, are common in females, and cystitis bladder infection represents the majority of these infections. E. coli causes the majority of uncomplicated cystitis cases. Among the pathogens responsible for the remainder are Staphylococcus saprophyticus, Proteus mirabilis, Klebsiella pneumoniae, Enterococcus faecalis. In general, under pathophysiology, there are three main mechanisms that are responsible for urinary tract infections. These include colonization with ascending spread, hematogenous spread, periurogenital spread. UTIs are common in females, accounting for over 6 million patient visits to physicians per year in the US. Cystitis bladder infection represents the majority of these infections. Related terms include pyelonephritis, which refers to upper UTIs, bacteriuria, which describes bacteria in urine, and candiduria, which describes yeast in the urine. So what are the signs and symptoms of UTIs? Dysuria, which refers to painful urination, urinary urgency and frequency, a sensation of bladder fullness or lower abdominal discomfort, suprapubic tenderness, flank pain and costovertebral angle tenderness may be present in cystitis but suggest upper urinary tract infection. Bladder urine, which is referred to as hematuria, then fever, chills and malaise may be noted in patients with cystitis, but more frequently associated with upper urinary tract infections. So how do you diagnose UTIs? So basically, diagnostic studies for UTI consist of dipstick urinalysis and culture. No imaging studies are indicated in the routine evaluation of cystitis. Current emphasis in the diagnosis of UTI rests with the detection of pyuria as follows. A positive leukocyte esterase dipstick test suffices in most instances. In females with clinical findings suggestive of UTI, urine microscopy may be indicated even if the leukocyte esterase dipstick is negative. Pyuria is most accurately measured by counting leukocytes in unspun fresh urine using a hemocytometer chamber. More than 10 white blood cells per ml is abnormal. Other findings are as follows. Microscopic hematuria is found in about half of cystitis cases. Low-grade proteinuria is common, and a positive nitrite test is highly specific for UTI, but it occurs in only 25% of patients with UTI. Urine culture remains the criteria standard for the diagnosis of UTI. Consider obtaining urine cultures in patients with probable cystitis if any of the following is present: immunosuppression, recent urinary tract instrumentation, recent exposure to antibiotics, recurrent infection, advanced age. So definitions of UTI in women based on culture results in clean catch urine specimens are as follows. Cystitis, more than 1000 colony forming units per ml. Pyelonephritis, more than 10,000 colony forming units per ml. Asymptomatic bacteriuria, in a female more than 100,000 colony forming units per ml in an asymptomatic individual. Any amount of uropathogen grown in culture from a suprapubic aspirate should be considered evidence of a UTI. So what's the management of UTI? Oral therapy with an empirically chosen antibiotic that is effective against gram-negative aerobic coliform bacteria. E. coli is the principal treatment intervention in patients with cystitis. The first choice agent for treatment of uncomplicated acute cystitis in women include the following: nitrofurantoin monohydrate macrocrystals, trimethoprim-sulfamethoxazole, fosfomycin. Consideration in antibiotic selection are as follows. Empiric antibiotic selection is determined in part by local resistance patterns. So that's all about urinary tract infections. Thank you.